On to discuss heart rates. Okay, what determines heart rate? And that's an important mechanism. One of the things that you have to make sure that you understand properly is that there's two things that really control heart rate. Okay, there's the electrical component that's generated by the SA node. So whatever really controls the SA node in a normal individual is really what's going to determine it, what the person's heart rate's going to be. The two major mechanisms that you have coming into this are parasympathetics, which is the vagus nerve, and the other system that's coming in are the sympathetics. Okay. There's two ways that sympathetics control your heart rate. One is due to the actual direct neural input, which actually releases the neurotransmitter norepinephrine. So the major neurotransmitter here is norepinephrine. Okay. The other way that sympathetics also increase heart rate is indirectly, and that's done by using the adrenal medulla. The adrenal medulla releases norepinephrine and epinephrine in the bloodstream, and then when the actual hormone circulates back and then gets to the SA node, it then increases heart rate that way too. So even though there's not a direct neurotransmitter release, it's a hormonal effect, which we call sympathetic stimulation from adrenal medulla, which is the epinephrine and norepinephrine that have the effect. So there's two ways to amplify increases in heart rate. As for the other side that's much more specific, which is decreasing heart rate, is only due to one stimulation, which is the vagus nerve. Okay? So there's no other way to slow down the heart rate unless you use the vagus. Okay? The only other way you can actually lose heart rate is if you knock out the sympathetics, then the SA node will go to its resting basal tone, which is normally around 50 to 60 heart rate. Okay, so if you lose both your parasympathetics and your sympathetics, the normal resting heart rate is around 50, 55. Okay, and you find that in patients that have been transplanted in, you'll see that their heart rate's around 50 to 55. Okay. Now, when you look at the actual SA node, you essentially have, let's say we'll just use a Great. Start erasing it. Let's say this is the SA node. You have parasympathetics coming in, and you have your sympathetics on the other side. The example to try to make you understand how this mechanism works is imagine that you have a seesaw. Okay, in that seesaw you have two individuals, one at each end. Okay? That seesaw tries to maintain a balance where the seesaw stays always at the same level. But it's always constantly changing, just a little bit. Okay? That's what we call heart rate variability. That's normal. If you take your pulse, it's not continuously 60 heart rate. It'll be 1 minute 62, next second it'll be down to 60, below that it'll be 58, then it'll cycle on and off. This cycling process is because the parasympathetics and the sympathetics shut on and off and to maintain a certain steady rate. The way you know somebody is brain dead is that you will see no variability. Okay, the variability will stop. Okay, so heart rate will stay steady with no changes at all. Okay, yeah. What's that? If you know that if somebody is brain dead, you will lose that variability. One of the tests for brain death is called the atropine challenge test. Okay? If you've seen that in the ICU, you see somebody given a milligram of atropine, and you'll see no increase in heart rate at all, because you don't have sympathetic stimulation as well as you don't have any parasympathetic that can be inhibited. Okay? Now the actual receptors that are important in this control mechanism. For the parasympathetics, The main neurotransmitter is acetylcholine, and the receptor here, okay, is a cholinergic receptor. Cholinergic. Okay? It also sometimes will be called an acetylcholine receptor as well. So acetylcholine receptor or a cholinergic receptor is the same thing. Okay? And that sometimes confuses students. Those are agonists. So if I give you a cholinergic or acetylcholine receptor action, you would expect the heart rate to decrease. Okay, that's a vagus effect. Okay? On the other hand, the neurotransmitter for sympathetics, which is norepinephrine, could be a norepinephrine receptor, okay? Or the way it's normally called, it's a beta-1 receptor. Beta-1 receptor accepts two kinds of neurotransmitters to activate. Actually, many kind of. The endogenous catecholamines like epinephrine, norepinephrine, tend to have beta-1 selective action. Dopamine also acts as a beta-1 selective acting agent too. Okay? You can get a purely selective agent where it only picks out beta-1, which is isoproternol. Isoproternol only affects the beta-1 receptor. Okay? So beta-1 is the one that's located in the heart. Okay? And by activating this, you actually cause an increase in heart rate, increase in contractility, and other effects. Now, drugs that affect this area specifically are also drugs that would be like mimic. Okay? If they're mimicking, they're agonist. Okay? So if I have an agent that's basically mimicking something that's endogenous, we call that an agonist. If it's something that inhibits or basically acts in a way that does not allow the normal neurotransmitter to affect, then it's called an antagonist. Okay? For the most common antagonist to decrease, to actually elevate heart rate, is atropine. Okay? Atropine, okay, does not by itself increase heart rate. Make sure you understand. It is not an agonist. Okay? It is an antagonist. It's an anti-cholinergic. Atropine is an anti-cholinergic. Okay? And it's an antagonist. Okay? What it basically does is it binds to the acetylcholine receptor, and it does not allow the parasympathetic activity to actually cause the heart rate to slow. So the only way that atropine works, though, is if you have an intact sympathetic drive. If this system is not available to increase the heart rate, then you will not see an increase in heart rate when you give atropine. Why is this important? You're going to be doing spinals and epidurals very soon. Okay? If you do that on a spinal, on a patient and you knock out all the way to the levels of T1 through T4, that's called the cardiac accelerator fibers, CAF. Okay? The cardiac accelerator fibers is what actually increases your heart rate. They're located between T1 to T4. So if you get a high spinal and knock those out, then if you give that person atropine, you will see no effect at all. Okay? And if you're in trouble, let's say you have bradycardia and hypotension, and you give atropine, you're not going to get anything. You're going to be very frustrated. Okay? If the person goes into a very deep parasympathetic activation, because the vagus still can function in that situation, because the vagus nerve comes from the cranial nerve. So the spinal hasn't knocked that out. Okay? It can actually drive the heart rate into asystole. So if you see that, the person's heart will actually stop. And the mortality rate of somebody going asystolic on you from a spinal is 99%. That's a pretty bad number. Okay? So if you do see that, the agent that you got to consider is a direct agonist. Okay? In this case would be epinephrine. Okay? Epinephrine would be your top choice if you're hypotensive, really getting low and severely bradycardic. Epinephrine would be the drug of choice in that situation. Okay. All right, so that's the first part of cardiac output control. Okay, one is, remember we said cardiac output is equal to heart rate times stroke volume. So the last slide sort of discussed what controlled heart rate. Okay, and the next part of this equation is stroke volume. What actually determines how much volume is going to be emptied from the ventricle. And believe it or not, all three things that we talked about before, which is preload, afterload, and contractility, are going to affect your stroke volume. Okay? And what I'm going to do is I'm going to expect you to know that based on just one change. So when I tell you in a test question, it says with all the other constants remained unchanged, which is don't change the contractility, don't change the afterload, what happens under normal conditions if preload increases? And the answer should be you see an increase in stroke volume. Okay? The other thing that's important about that is that you don't see any change in your left ventricular end systolic volume, okay, which I'll show you what that means in a minute. Okay? If you do your pressure over volume curve, this is your preload. Let's do our normal first. It goes here, here, here. Okay, now do our contractility line. Let's say it's here. If all we're going to do is we're going to say we're going to increase preload only. So we're going to go from this point here, we're going to move up. In this case, we're not in the failure portion, so we're going to say it's going to go up to the same afterload point. Okay, when we reach that, then we're going to eject to the same contractility line. So what happens to my left ventricular end systolic volume? It does not change. All we are changing when we're saying, make sure you show the difference, because they did that 2 years ago in a board exam question, and some of the students didn't catch it. Okay? This volume, left ventricular end diastolic volume, is increasing. That's a description of an increase in preload. Okay? But the left ventricular end systolic volume is unchanged. ESV. Okay? End systolic volume. So under normal conditions, you see, because it's part of Starling's law, as you increase preload, you increase your stroke volume. Okay? Now what happens if you change your afterload? Okay? In that situation, if you increase your afterload without changing the preload or the contractility, again, we're only making one change at a time. Let's do the normal first. Okay. Your only change that you're making is at this point, your afterload. In this sense, we're going to say that we're going to increase the afterload. The person is going to get hypertensive, in other words, okay? So we increase the afterload. Okay, the preload's unchanged, and the contractility line, which is this line, it's not changing. So what happens is this person will come up, eject, and come down. Okay, sorry, it's not quite vertically downwards, but somewhere like there, okay? What do you see change? What did not change was your left ventricular end diastolic volume did not change. But what did change was your left ventricular end systolic volume actually increased. So if you increase afterload, the heart is unable to empty appropriately, completely. And what will happen over time is the ventricle will begin to fill and may actually drive it into failure. Over time, the preload curve will shift upwards. This will start shifting this way eventually. And if it keeps pushing it, you'll start doing that. And eventually you'll hit the preload point where you actually develop failure. Okay, that's a compensatory mechanism that you see. Okay? What you're doing with your increasing afterload like this, you're increasing the amount of cardiac workload the heart's doing. So as a consequence, increases in afterload have significant risk of developing ischemia on a patient. Okay? All right, as for the contractility, what happens when you change that? If you look at the normal curve, let's do our line here. Okay? Let's say in this example we're going to increase contractility without changing anything else. Okay, we're going to shift the line more vertically like this. Okay? What will happen in this situation, preload's starting the same, afterload's starting the same, and you eject it all the way out here, So increasing contractility, what happens to your left ventricular end systolic volume? It goes down. Okay, so increasing contractility actually helps empty the ventricle more efficiently. Okay? So how do you actually determine cardiac output? Well, you have to take the two things always into consideration. You have to take your equation and always consider these things: heart rate and stroke volume. The heart rate is mostly controlled by the autonomic system, which is the parasympathetic and sympathetic, okay, with the sympathetic binding selectively to the beta-1 adrenergic receptors, which then lead to the secondary messenger system, which is cyclic AMP. And that becomes important later on when we talk about phosphodiesterase inhibitors, where cyclic AMP comes back for the discussion. Okay? When you bind to beta-1 receptors, you increase the velocity of heart rate, so chronotropy is increased, so you have a positive chronotropic effect. You see a decrease in cardiac action potential. You see an increase in the rate of action potential conduction, so you have a positive dromotropy effect. You see also a positive inotropy effect, which means that contractility is increased. Then you see what's called a positive lusotropic effect, which is the relaxation of the heart is improved. So all these effects are good things. Okay? And that's all your beta-1 activation. As for your stroke volume, that's related to preload, afterload, and contractility. Okay? One of the things that you got to pay attention to is watch your Starling's curves. Make sure that you're having adequate cardiac filling. As before you try to eject the volume, you have to have enough volume in the heart. And what happens when you increase sympathetic tone to contractility and the filling? If you increase heart rate, normally the ventricle will empty more fully. Okay, so it actually helps drive down somebody who has failure. Okay, that's why the heart goes into a more rapid heart rate. On the other hand, if you decrease heart rate, okay, and somebody's in failure, you're actually going to make it worse. So putting a beta blocker on a patient who's in failure is really contraindicated. Beta blockers are placed in patients that are in failure after they've been treated, and then they're put on beta blockers to decrease the incidence of ischemia. Remember we talked about how heart rate increases the workload? Okay? So if you increase the workload too much, then the heart gets ischemic and it begins to dilate. And that's when you get into failure. Okay, so that's why it's useful in that situation. But under normal circumstances, the person's in failure, the last thing you want to do is add a beta blocker at the time. You want to wait till they're treated first by diuretics, decreasing their preload, and then you add the beta blocker. Okay? This is what I sort of want you to understand, the mechanism of what's maintaining heart rate and overall cardiac output. So everything on the green side indicates to you an improvement in cardiac output. Okay? So normally the increased sympathetic tone has a positive effect by increasing heart rate. That helps. And it also increases stroke volume. The limitation of a sympathetic discharge is too much afterload increase. Okay? So if you increase the afterload too much, in other words, you increase the arterial pressures too much, that begins to actually affect the performance of the ventricle. So that's the downside of giving somebody and making them hypertensive. A disease process example like this would be a person with pheochromocytoma. Okay, a person with a pheochromocytoma is a tumor of the adrenal gland where the person begins to secrete high doses of either norepinephrine or epinephrine into the bloodstream. And the danger of that is if somebody decides to put that person on a beta blocker first, okay, which you never do. You have to give them an alpha blocker first or a combined alpha-beta blocker. Okay, if you give them a selective only a beta blocker, what will happen is you won't be able to increase the heart rate to overcome the negative effects of very high afterload, and the heart may actually stop. Okay? So giving somebody very high doses of an alpha agent is actually very dangerous. Okay? The other example you may see this is, let's say you're using neosynephrine. Neosynephrine is a pretty much selective alpha-1 agonist. So if you give really high doses of that, person's blood pressure will be in the 300s range or higher. Then you'll see the heart rate will get very, very slow, like in the 30s or 40s, and the person will then stop. actually ejecting their cardiac output. Okay, that's another one that's pretty dangerous. You can see people making that mistake. I had one student many, many years ago do this when I was a resident. The individual did not read the medication appropriately and thought he was giving the antibiotic, what's it called, not gentamicin, but starts with an N. Neomycin. He was going to give neomycin. Instead, he pulled out the actual neosynephrine and put 4 vials of it into the actual drip, and then began to give it as an IV drip. So that was not a good day. Okay, the blood pressure was 340 when I first came in, and then figured out what was going on, shut the medication down. The patient woke up, thank goodness, and did fine, but the heart rate did get down to 20. We were getting a little worried there. So that's a little bit. That's what you call as a reflex bradycardia. What's happening at that point is your brain saying, look, enough blood flow to my head, I'm going to explode. So, the heart rate tries to slow down so it doesn't get any more perfusion to the brain. So you want to sort of avoid that situation. Okay, the other one that also is a negative, and that's why it's red, is a parasympathetic because it does slow down your heart rate, so as a consequence decreases your cardiac output. Okay, your body is constantly trying to maintain this steady. Okay, it's trying to maintain a steady cardiac output depending on the needs of the patient's body. Okay, most of the systems that actually regulate this is the brain. The brain knows how much perfusion is needed for the rest of the body. It's actually measuring that constantly by the degree of perfusion is getting to the brain. Okay, so it's we'll talk about that another time, but it's ultimately these control mechanisms here are regulated by the brain. Okay, cardiac energetics is the last part of this discussion. Okay, and I was asked this many years ago by one of my students who said, well, why is it that the heart works differently than the rest of the body? Like if you look at the brain energetics, the brain uses mostly glucose. Okay, glucose is its main energy storage. Okay, and if you lived in the 1980s, 1970s, one of the things that you were told to try to lose weight was to go into a non-sugar diet. Sorry, a non-fatty diet. That you had no fat at all. You can eat all the sugar you want, but no fat. Okay, and then we went the other way around, where we did only proteins. So people are crazy either way you go. Okay, you got to stay steady with your energy needs. Okay, if you don't eat, if all you eat is sugar, your brain stays happy. But what begins to happen very soon after that is the muscle in the heart begins to fail. And that's when we finally figured out that the muscle, which is a heart muscle, doesn't use sugar as its main energy source. It's actually very inefficient for the heart. Instead, the heart uses free fatty acids. Okay? So a little bit of fat in your bloodstream is actually good. Okay? Over too much is not good because it develops cholesterol deposits in your arteries, but that's different. Okay? But if you don't have enough fat in your fatty acids getting into your bloodstream, then your heart begins to deplete and will actually develop cardiomyopathies from it. Okay? And we saw that during that time period. Okay? The mitochondria actually metabolize the fatty acids with 60 to 90% of the total energy production, which is quite a bit. Okay? And the carbohydrates only contribute to 10 to 40%. So if you are trying to exercise and lose weight, okay, and you can't extract it because all you're doing is you're eating just straight sugar diet, and then pretty soon you're going to burn out your heart, and then that's what was happening to these individuals. Okay? These mitochondria what actually produces the ATPs, and it actually produces it much more efficiently with the fatty acids. Now, where is the energy source used mostly? And that is actually during osteovolumetric contraction phase. Okay, the energy sources that your body needs is to produce eventually ATP. What we call the essential nutrients, or the whatever gets to your oxidative phosphorylation pathway, which is the tricyclic acid pathway. So to be efficient, the heart uses some degree of glucose and pyruvate, but it really uses mostly free fatty acids, triglycerides, and ketones. The heart has very limited storage for glycogen, although there is some storage, so it's not zero. Okay, it will last you for about 15 minutes. Okay, and that's why the heart will last longer than the brain. Okay, well, usually you'll see somebody be brain dead in 5 minutes because the only source of energy that the brain uses is glucose. Okay, it does not like using free fatty acids. Okay? The end product metabolism is acetyl-CoA before it goes into the Krebs cycle. And the end product is ATP, CO2, and water. Okay, and that's and also heat. That's what it's forgotten here is heat. That's the other end byproduct. Okay, so your heart not only produces CO2 and water, but it also produces heat, and as well as ATP. Now, it's not if they ask you in a test question, what is a nutrient? A nutrient is basically sugar, fatty acids, amino acids, and proteins. All those are nutrients. Okay? Oxygen is not a nutrient. Okay? Oxygen is a substrate. Okay? So it's required for life, yes, but it's not something you're consuming. Okay? It's something that you're taking in from the environment. Okay? If you go anaerobic, okay, the oxygen can no longer uptake that last bit of electrons to keep the oxidative phosphorylation system going in the actual mitochondria. Okay, so without oxygen, you die very rapidly. Okay? The normal time period for the brain is around 5 minutes before it dies, or begins to die, and it causes significant damage. For the heart, on the other hand, because you do have glycogen storage and you can go anaerobic for a little bit longer, you're looking at 15 to 20 minutes before it starts to die. Okay, so it does last a little longer. Now, one of the things that you see in the heart, though, and tremendously compared to the brain, is that you have huge amounts of mitochondrial stores. Okay? The reason being is that the heart is actually consuming 70% to 60% of what the oxygen is delivered to it and actually using it. The brain only uses around 40%. So it's not using as much energy. Okay? There's also some more complex molecules that are inside the heart that actually act as storage and actually begin to extract the oxygen at a much rapid rate and acts as a storage device to hold the oxygen inside, okay? Which is partly myoglobin is what we have inside the heart as well. So it acts to have a high affinity oxygen and it holds it for the mitochondria as stores. So understanding how these nutrients are being used and how oxygen is being used, we've been actually using different kinds of medications to hopefully extend the survival time of a heart that is actually hypoxic. Okay? And this is treatment that you're going to see over the next few years where we can actually either limit the amount of acetyl-CoA for a limited period of time. By limiting the heart exposure to some nutrients, it converts the heart into a state where it understands that it's going to go into a low oxygen state. Okay? As a consequence, it actually causes the DNA to change inside the heart muscle, and it begins to extract oxygen at a higher rate. Okay? So it actually improves survival. So we're actually finding out that there's actually the heart that's being previously exposed to hypoxia actually increases its survival in the subsequent exposure to hypoxia, which is kind of interesting. So we're developing different kinds of therapies, and you guys will get exposed to this over the years, that will give prior to going on a bypass or maybe in a week or two beforehand to try to help that person so they don't develop hypoxic muscle damage to the heart. But this is still in the infancy right now, but I think it's something that's going to come back to become important by the time you guys are finished up. Your determinants of myocardial oxygen consumption, ATP is consumed at pretty high rates for the heart. Okay? 25% is actually used for basal metabolism, and the actual contraction phase consumes the other 75%, which most of that, which is 50%, is used during the isovolumetric contraction phase. Okay? No external work is being done during that portion of the time. Instead, the actual isovolumetric contraction is determined by the cardiac afterload. So decreasing cardiac afterload is actually helpful. If you want to really improve somebody's survival for oxygen utilization, you can decrease the afterload and you can actually, as a consequence, give that heart more ATP storage capability. Okay? So one of the first things that we actually treat people that have congestive heart failure is actually ACE inhibitors. Okay? The ACE inhibitors are selective afterload reducers. Okay? So that actually helps the performance of the heart over time. This cardiac workload, of course, is dependent on the isovolumetric wall tension. The greater the wall tension, the more load work is being exposed to the heart. So decreasing that is helpful. Okay? The other thing that we know is also reducing preload to a certain point will also decrease oxygen consumption, which is important. You don't want to put the person over the top of the Starling's curve, because then you're really in a bad place. The muscle is maximally dilated at that point, and its isovolumetric wall tension is very high at that point, and the heart's going to work even harder to try to pump during that phase. Heart rate depends on what situation you're in. As long as heart rate's maintained between the normal range between 60 to 100, most people will say that's the ideal situation. Once you get up to 120 heart rate, cardiac performance continues to improve linearly. But once you get above 120, 130, that's when performance begins to drop off. Okay? At that point, there's not enough time to fill, and you start losing the ability for the ventricle to contract appropriately. Okay? Now, one of the things that the book talks about a little bit was the stroke work, which is the area in the curve, which is when you look at the pressure over volume curve, they're talking about this area in here. That's the stroke work. Okay? So anything that makes this area inside here bigger, it doesn't matter how, it's going to increase the stroke work. Most stroke work is going to increase dramatically if you increased the afterload. Okay, so if anybody asks you in the exam, where does most of the cardiac workload increase? And the answer is it's going to be increases in afterload, because it increases your isovolumetric contraction phase time. So hypertension is kind of a bad thing. It's most costly in ATP utilization, and so it becomes a big issue. ATP production, of course, is dependent on coronary perfusion pressure, which we'll get that in a minute. Okay? But how much oxygen is being delivered to the heart muscle is dependent on coronary blood flow. Now, the actual measurements for cardiac function, you can do several different methods, and I'm not going to go into all of them. There's a Fick method, the dye dilution method, which used to be done in the past. Where you actually, and you still see it when it's done in the cardiac suites, they actually will shoot dye into the left ventricle and see how much of that dye is expelled into the aorta. And from that, they can actually describe percentage-wise how efficient the heart is. The way we do most cardiac outputs nowadays is via thermal dilution. Okay? What we do is we actually heat up the blood and then now the continuous cardiac output. In the old days, which is still the way we most commonly do it still, which we should call it the present day, is that we inject cold solution into the ventricle. The cold solution then will equilibrate with the temperature around it depending on how much time it has. The longer the time inside the ventricle, the colder the fluid is going to get. So the actual cardiac output performance, showing you this increase in coldness, shows you that you have a higher, this value looks like this, the lower the cardiac output is. It's measurement in temperature. If you see the curve being very small, it means that there's not enough time because the ejection is so efficient that you don't see enough change in temperature. In the old days, when I first started, we used to have to inject 10 cc's of ice solution into the heart. How many people had to do that? Let's see, to show your age, okay? Most of the rest of us have now, since that time, just inject 10 cc's of just normal room temperature fluid into the patient. The thermistors are much better in quality nowadays, so you can measure the temperature change rather easily with them. Okay? Cardiac contractility estimates are a little bit more difficult to measure. The best one that we have available right now is echo, okay? Echocardiogram. The second one that's used for imaging is cardiac angiography, as well as radionuclide ventriculography, okay, which is what we call sometimes a MUGA test. Okay? The ejection fraction is something that measures the total stroke volume over your end diastolic volume. Okay? In the normal range, should be around 55 to 80%. Okay? No, most of us in this room have a 65 to 70 cc stroke volume for every time your heart pumps. If you're an athlete, it could be as high as 110. Okay, so but most of us here are around 65 to 70. Okay? So when you're asked about an EF, you're trying to always achieve at least a 70%. That would be optimal. Once you get down to 50%, mortality rate doesn't really change. But once you start getting down to numbers of 25%, there's an increase in risk. And then once you get down to 10%, the risk is way up for having a severe problem. Okay? And if you're down to 5%, which I've taken care of in the past, and you all will eventually if you stay in Naples, all medications take forever to get there. Okay? If you give a medication in somebody's hand, this is a common mistake that people make. Okay? One of the reasons that we ask about EF is because it tells you how fast the heart is pumping the blood around. The faster the cardiac output, in other words, the better the cardiac output, the faster the medications circulate around. Okay, and you'll see that when you take care of a young person, you give them the Diprivan and the succinylcholine, it's almost instantaneously that they're asleep. Okay, versus if somebody who's older and you give them the medication, the person's sitting there talking to you. And you're going like, wow, did this even get in the vein? And you're sitting there and you're sitting there and you're sitting there and you're going like, man, what's going on here? And if you're impatient, what you'll do is you'll follow up and give more. What's happened is it's still in the vein. Okay? And by the time it hits the heart, you're just going to get the secondary dosage you just gave, and now you're going to overdose the patient, and you're going to be in big trouble. So be a lot more patient with people with low EFs. That's how people get in trouble with giving Versed to somebody who has an EF of 5 to 10%. They'll give 1 milligram, and they'll wait. And they normally expect the person to be asleep in about, or sedated in about a minute and a half. Not a big deal. But this person, 7.5 minutes later, they're saying, that doesn't do anything to me. And so you give them another milligram. And you give them another milligram. Okay, now you're at 4 milligrams without even noticing, and soon you turn around, the person's apneic and dead. Okay, so be careful. Okay, that's where it's important for you to understand that concept. All right, see what time we are right now. I'm going slow rate today. Okay, I'll give you guys a 10-minute break, and we'll start in chapter 4.